Hello, how are you?
How are you? Fine, thank you. And you?
All good, all good. Going to.
Dr. Sabu, I am going to ask you some questions about your talk. I'm going to introduce you first and then ask you some questions for Argentina, for the
Tell
Argentine.
me,
Okay,
sure. So what question you want to ask me? Tell me. And how much
excuse me.
time it will take?
Excuse me.
How much time it will take?
15 minutes. Is it okay for you?
15 or 50? 50 or 515?
10, 5, or 10?
Okay, good.
Okay. Is it okay for you?
Yes,
Or
yes,
10
tell me.
maybe, or 10 maybe. Well, I'm going just to introduce you. Well, it's my pleasure to introduce Dr. Vansi
So
Shabu.
why don't you keep your laptop slightly near so the face you can see like me if you are
Excuse me,
recording it?
excuse me, excuse me. Yeah, I
Yes,
didn't
why don't you
understand.
keep your face? Yes, now you are looking better.
Yes, because I was just reading what I
No, no, but you should
is
look,
it okay? Is
and
it okay for
yes,
you?
now fine. Good, good.
Well, it's my pleasure to introduce Dr. Vanshi Sabu. He's a distinguished diabetologist from, I'm sorry if I don't, Ahmedabad, in India, internationally recognized for his contribution to diabetes care, diabetes technology, and continuous glucose monitoring. He's the founder and chairman of DiaCare, Diabetes Care and a Hormone Clinic, and has authored numerous publications on diabetes management and digital health. We are delighted to have you with us. Um, well, Doctor, it's amazing how you could in India introduce the technology and improve the diabetes care. What I know that you are part of this program, which is so important in India. So we wanted to know a little more about it. It's what you talk in the last ADA meeting.
Yes. So first of all, thanks for kind words of introduction and inviting me on this platform and to talk to you on this. And I'll be very happy that the audience from Argentina is listening it, and it will be my pleasure to talk more about the different programs which we do. So just to introduce myself, I'm currently uh, chair of International Diabetic Federation of Southeast Asia. So this part of the region of the world, I'm the chair currently, and I'm the board member of International Diabetic Federation. As Argentina is part of SACA region, which is known as South America and Central America, under which Argentina is a part of IDF, and I'm the chair for International Diabetic Federation Southeast Asia. I'm heading Diabetes India. So we were having this year an American Diabetic Association has in two important topic which was given to me, and one was on a global obesity care, for which I was invited to give a talk as I am past president of Indian Obesity Society and as a diabetologist. I talked about that. And the second was on the how the data is going to change the policy, but I'm the founder of Diabetes Technology, which is DTech, which we have started in India. And as you know, the technology is very, very important for reaching out to the people, distantly. And at the same time, this technology had improved the care for people with diabetes. Internationally, there are two important meetings on diabetes technology are going. One is ATTD, which is Advanced Technology in Therapeutics in Diabetes, which is in Europe. And in US, there is a Diabetes Technology Society. Luckily, I'm part of both these meeting, and we have started our own in India on ATTD, on the basis of ATTD, which is we call it diabetes technology. All over the world, still the accessibility and access to these technology is not there because of the cost, because of the availability of these newer technology. But in India, we have some of the technology, but all the technology are not available. Newer latest insulin pump by Medtronic is there, 780G, and we have continuous glucose monitoring, which is Libre 2 Plus. These continuous glucose monitoring has changed the way we were treating diabetes before a few years. Now, today, a diabetic patient to whom you put on continuous glucose monitoring, and he can be distantly monitored in your clinic also. On your desktop, on your laptop, you will be able to know what his sugar level. And not only that, it can be also shared with his relative or a friend, or he may be anywhere in the world. Still, the technology is like that, that continuously you can monitor his sugar, and the patient himself can see its sugar on his mobile phone. It has changed the way how they are eating. Their eating behavior is changed. They see their report, and accordingly they change their diet pattern, their exercise, their therapy also gets changed. And we also write the medication to improve the care, at the same time to take care of the post-meal glucose level. But one very important aspect, that it reduces significantly hypoglycemia, particularly those who are on insulin, on sulfonylurea, because continuously you are saying, and midnight hypoglycemia, nocturnal hypoglycemia, which is very significant reduced because it has got alarm system also. So if your sugar goes down less than 70 or 80, there will be alarm also, which will not allow the sugar to go down suddenly. So these are some of the very big advantages of continuous glucose monitoring. The only challenge is present is India. Patient has to pay from their pocket. It is on their own pocket. They have to pay. So cost is a challenge, and that's the reason that each and everyone is not getting the benefit of it. But I'm sure in future, the cost of this technology, the continuous glucose monitoring, will significantly reduce. And developing countries like Argentina and India, most of the people will take the benefit of this continuous monitoring. That's what I think. At present, only the Western world and the currently who are developed countries like US, Canada, all West Europe, and Japan, Singapore, some of the developed countries are really enjoying the benefit of continuous monitoring, including Australia, but I'm sure it will be available to every one of us.
Yes, well, in India, the work that you have done is fantastic. I know that you have lots of barriers, and the electricity, the internet access, etc., could affect the use of lots of these tools. What can you tell me about it?
So I agree, in the rural part of the country where the electricity is a challenge, or the transportation is a challenge, or the accessibility of the challenge. But I should say, know, in the world, that in last 10 years our economy has grown significantly. We are one of the fastest growing with GDP, and our rural infrastructure improved significantly. So now I will not say that the rural people are not getting the electricity, or they will not get all these things, because that now what is needed is information is there is a availability is there, accessibility is there. It requires more education for the people who are living with this particular condition. So they should understand the importance of all these things. And the second, they feel sometimes, the patient feel that I have this much income. Should I put for my investigation? Should I put in monitoring, or should I put for the newer medication? Now GLP-1 and SGLT2 also become off patent in our country. And that's the reason many patients are getting the benefit. But would we convince all our primary care physicians to use GLP-1 in their clinical practice, or SGLT2 in their clinical practice? Probably no. But down the line, I'm sure in coming years, 2, 3 years, we will able to, information. We will pass on this information to all primary care physicians. We will educate them, and I'm sure more people will able to write for these companies.
What I have read is about Indian people, that they are not, the prevalence of overweight obesity is lower than in the States or maybe Europe. But that one article that you are co-authored, you told us, or you wrote that even if the overweight obesity, the weight or the BMI is lower, you are maybe a little more insulin resistant. Is it
Very
that?
true. Great question. Because the Indians are thin fat Indians. So even at lower BMI, we have higher fat percentage. And that's the reason we have come out in 2009 on the Asian cutoff. So we will not call somebody whose BMI is more than 30 obese. Rather, we started calling someone who is above the BMI of 25 is obese. And with 23 plus, we call it overweight. And our absolute normal BMI is between 21 to 23. And we
Okay.
look for more fat percentage and muscle mass, because this is two things which are very common. We have less muscle mass and we have more fat. So we get the benefit of these newer drugs more in terms of CV protection and renal protection. And that's the reason we are advocating it very, very strongly that using semaglutide in our day-to-day clinical practice is really very effective in preventing these complications, and as cost had also become less, so that becomes also a beneficial point for us.
You know that we have done some research in the north of Argentina, in the Andes foothills. And this indigenous population had a higher insulin resistance, even if they were thin, and they had a high dyslipidemia, high triglycerides, and low HDL. Do you have the same or similar?
Yes, so we have similar issue, which is known as Indian phenotype. Our lipids are very typical of high triglyceride, low HDL, high LDL, and with particularly ApoB is high. So LDL, even if you find around 100, but if you do the ApoB, you will find it's 120. And that's the reason we have highest number of CVD cardiovascular disease problem in our country compared to any part of the world. WHO is also working very closely with us. NCD Alliance, we are working very closely, and we just want to increase the awareness and prevent the complication of diabetes and prevent the complication person with obesity also.
And the last question, because I know that you're really occupied, but how many people in India don't know, they don't know how to write and read? Do you have
So
I don't
you
know,
are talking of literacy rate. If you ask me, the literacy is good. It's not like that
okay,
people are
okay,
around 70%, but still there are people who can't write, and that's a little. But if you just see the in last 30 years, everybody started going to school. So those who are now today young boy or young girls, even young adolescents, they all are educated. The problem is with the older people that before 50 years,
okay.
people not used to go to the schools and that.
Okay, so it's fantastic. And I always
Yes,
read
we
about.
can say it's a good, I mean, not fantastic because 100% literacy rate is not there.
Well, you'll have it because if you go
Yeah.
in this way, you'll have it early. And the way I always, when I read, I always read because India, the technology and diabetes, and that's why diabetes is so fine in India and the progress. And I know that's you. Now
Thank
that
you.
you are part of this.
Yes, yes.
So congratulations. And I hope in
Thank you.
Argentina we can do the same. It's really difficult
Sure.
because we have not the
But
barrier,
there
not
can be always, Indo-Argentina, and we can always have, South America and some collaboration which will help us.
okay, okay, thank you. Here the barriers are like the money because we have electricity, we have internet, but this the public and and even the private systems, they put always barriers for CGM and for AID, and we know that that's the best for our kids and our children and our adults with diabetes.
I agree with you fully. Children with diabetes, AID and CGM is the dream for everyone. But the first thing we have to educate the primary care physician, healthcare professional, and at the same time they should demand for it, and the patient should be educated and they should be made aware about all these things. Your therapy at present, because it's a out-of-pocket expenses. Out of 10 people to whom we educate and explain them, only one of them is taken. It's like 9 of them still will wait for some.
Yes. Well, Dr. Babu, thank you very much for your time. I
Thank you.
know you are very busy, and we'll put it in YouTube and I'll send it to you. Okay?
Thank you. Thank you. Thank you. You send me please on WhatsApp video and we will be circulating it also. Thank you.
Okay. Thank you. Have a nice day.
Bye bye.
Bye bye.